And now let's move on to Dr. Vivek Shanmugam, who's with the Chennai Liver Foundation in India. Vivek.
Good evening, good morning, everyone, and thanks, John and Lindsay, for inviting us for this lovely webinar. Today, I'll be speaking about the role of point-of-care testing and how we can scale it across health systems, particularly by integrating screening into community-based settings. My focus today will be on practical, scalable models derived from our own experience. Okay. Right. I think we're going to see this slide over and over again. But Hep B continues to be a silent epidemic. Globally, a lot of people are living with chronic Hep B, and every year we see over 1.2 million people with new infections. But what's more concerning is that only 10% with Hep B know their status, and only less than 2 are on treatment. This massive diagnostic gap is what fuels liver cirrhosis and liver cancer, and is the reason why community-based screening becomes an absolute essential. The cascade of hepatitis has got multiple steps like testing, linkage to care, treatment, and monitoring. And what it requires is multiple levels of blood testing too. And if each time a patient has to come to the hospital for a blood test, it becomes cumbersome for the patient, cost becomes high, and many a times that's why they're lost in follow-up. So the key is taking the care to the patient. HBV is largely asymptomatic until very late in the disease. So waiting for people to come to the hospital clearly doesn't work, at least in India. Community screening allows us to reach vulnerable groups, people in remote areas and individuals who rarely visit health facilities. It brings prevention, testing, and awareness directly to the population that need it most. Despite the availability of effective tests, screening is still fragmented and opportunistic. It ideally should be more systematic. More testing happens among blood donors, pregnant women, and people who go into the hospitals. But adult men, adolescent, migrant workers, rural populations who are healthy are hardly reached. Stigma, lack of awareness, and poor integration across health programs further reduce the impact. These gaps directly translate to misdiagnosis and ongoing transmission. The core objective is simple. We want Hep B testing to be universal, accessible, and stigma-free. Integration allows early diagnosis, timely linkage to care, vaccination of contacts, and overall reduction in transmission. When hepatitis service becomes part of a routine community health delivery, the entire systems become stronger and more equitable. So this is our own published paper where we did a Markov modeling to understand the economics, the health economics of hepatitis B testing. We clearly demonstrated that decentralizing a linkage to care and vaccination has been significantly better than the conventional approach of screening patients who come into a hospital. So this was, we published this quite some time ago, but unfortunately still, it's not been adopted in our country. So there are multiple existing platforms, like my previous speaker alluded in his lovely talk, where they combined the antenatal screening with hepatitis B. Of course, you can screen in primary health centers, health and wellness care centers, and of course, NGOs like us do a lot of outreach programs where we go out in the community and screen these peoples in various health camps and mobile units. And of course, the huge chunk in India, which we feel is a private practitioner. The health system is skewed where a lot of people go into the private sector rather than the public sector. So I think the private sector should also be tapped into and encourage them to screen these patients, and if found negative, then they have to be vaccinated. Each of these settings provide a unique opportunity to expand screening without needing any major infrastructure. Now, this is our own foundation, Chennai Liver Foundation. Of course, you can see my father on the far right. We've got a mobile van which runs around on a day-to-day basis in various towns and villages. and a lot of CSR partners help us overcome barriers faced by the government facilities. We reach the undeserved areas, urban slums, schools, workplaces, and migrant populations. Their program often includes education, testing, which is critical for reducing stigma and increasing health literacy. Flexibility is a major advantage. We can operate outside rigid government rules. Of course, health camps, typically we always liaise with the local governmental organization or another local NGO or another CSR partner or another social organizations like Lions or Rotary, and the people are informed well ahead that such a camp is happening. And it's highly visible. We generate a lot of awareness. A lot of pamphlets is being distributed. And of course, we always have counselors in such gatherings where they can educate them straight away. What is important in our camps is that once found positive, blood is drawn for higher testing. And of course, for those who are negative, we always vaccinate all these people straight away. Of course, this is our, again, published paper we did about 7-8 years ago, where over 75 camps across, I think 14-15 districts of Tamil Nadu. We had a HBV prevalence of 1.63 and a HCV of 0.3, which probably is slightly different now. But what we realized is community health camps remain one of the most effective ways to reach large populations in a short time. Camps can be standalone hepatitis events or integrated with what we do now is a non-communicable disease screening, which is diabetes and hypertension. People receive rapid testing, counseling, and vaccination. And those who test positive are linked to government or private specialists for confirmatory tests and treatment. Thereby, linkage to care is never, ever, ever missed in any of our camps. Of course, this is, I couldn't pull out the data in the last year or so, but this is the last 4 months alone. We've screened close to 2,500 people. And as I said earlier, we started screening for diabetes and hypertension. In fact, we picked up a lot of diabetics and hypertensives because India has got a lot of metabolic diseases. And of course, at the same time, we screen for B and C as always. So we compare our screening models, integrating screening into clinical services. And we understand that when clinical services do screening, it's least costly because infrastructure is always there. But what happens is we screen less number of people because people walking into any hospital is very less. But then when you go out into the community, the screening becomes more, but the cost marginally increases. Expanding community-based screening to include multiple groups further increases the cost per screening because of additional management costs. But I personally feel it is worth it screening for other diseases at the same time because that attracts more people into the community. So two things which I have noticed over the last few years is that when people go out for screening, they draw blood, come back to the institution where they come from, and do a testing in the lab. But I feel the point of care testing is the best. Point of care testing is central to scaling hepatitis screening. They're fast, accurate, require no lab infrastructure, and can be done by frontline workers. POC testing allows diagnosis, counseling, and vaccination to happen all in one encounter within a matter of 15 to 30 minutes. It reduces loss of follow-up and improving linkage to care. This creates a powerful public health advantage. So we almost always do in the community point of care testing with recognized test kits. Of course, we all know the WHO criteria, the assured criteria, where the point of care testing should be affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and of course, easily delivered to the end user. There are various studies around the world which show that point of care testing is extremely cheap. This is one from Belgium, where the migrants in Belgium were screened, and it's clearly demonstrated that POC testing at a lower cost when compared to venipuncture sampling. This again, yet another paper from Guatemala, another LMIC introducing point of care testing and antenatal screening showed that they The increased antenatal coverage by 32.5% as shown by our previous speaker, and the hepatitis B screening from 0 to 42.2%. That is quite an increase. So there is no doubt that point of care testing is very, very beneficial. So for successful integration, we need consistent supplies of a rapid diagnostic test, well-trained frontline workers, simple referral pathways, and data integration and digital platforms. Community engagement and political commitment are also critical enablers. Stigma remains the biggest barrier. People fear testing due to misconceptions. Supply chain brings, weak referral systems, and limited follow-up are other challenges. Strengthening and coordination between the PHCs, district hospitals, NGOs, and private providers is quite essential, else the whole system becomes a failure. A robust monitoring and evaluation framework is required. We need to have all the indicators as the number screened, how many are reactive, how many confirmed, and how many have been linked to care. And extremely important that we offer vaccination services in the community to people who've been detected as negative. And of course, we always integrate all the data with the National Viral Hepatitis Control Program. These metrics allow programs to track and impact and refine the strategy. And summary, if we integrate point-of-care testing, hepatitis B testing across platforms, we can drastically reduce the burden of hepatitis B and move every country to closer to elimination. Of course, there are still many unanswered questions regarding funding mechanisms, program sustainability, best way to ensuring linkage to care, especially in a country as big as India, and how to develop, select, and implement the most cost-effective strategies of screening, disease surveillance, and community engagement. But still, I think if all of us join together, I'm sure this is going to be a reality, and by 2030, we will eliminate viral hepatitis. Thank you very much.
Thank you very much, Vivek. Excellent presentation of the published data and your own experience locally. And you bring up the role of multiplex testing in community-based screening programs, and that's something we really want to focus on in our panel discussion. There's also several questions in the chat from my colleague Vivian Wang regarding the known sensitivity and specificity of the multiplex test and which manufacturer is producing the tests that are being used in India and Kenya. So if you have answers to those questions, please send those on at this time. And if not, we'll raise those during the panel